Hello and welcome to the second of the videos. We're looking at a topic which in many ways comes up both directly and indirectly in interview questions. Directly, they do like asking questions about healthcare rationing, particularly with the COVID pandemic. We saw a massive rise in rationing based questions, which were obviously themed around COVID. We've touched on quite a bit of the ethics of that in our previous session on ethics. So I'm not going to recap that, but I'm going to cover the particularly focus on how you would answer a question which is more generally about rationing. Most of the time, students are fairly good at understanding there are limited resources in the NHS and in any hospital at one time, and given extreme circumstances, stuff has to be rationed. It's the basis, for example, of triage that we'll discuss. However, there is something called lifestyle rationing, which is gaining currency amongst certain CCGs and is being wheeled out more and more, which particularly is a complex and very, very politically charged issue, which gives you particularly something interesting to talk about in your interview. In addition, it gives you the opportunity to talk about, or give you a point, apologies, to talk about when you're given a question, for example, on how to make cost changes in the NHS, or ethical issues as they arrive in the NHS, or health inequalities in the NHS. So the focus of this is, although we're talking about rationing more broadly, either it's very straightforward, or we will recap certain elements of it in the first slide, or we've already mentioned it in ethical terms in the ethics session. So we're focusing primarily on this specific type of rationing, which is lifestyle rationing. So, to start, rationing, by definition, is the deliberate limiting of available treatments which are traditional and possible in the NHS. What that means is it's not, say, if we think of the session we looked at last week, which was about denying certain drugs because they're not cost effective. That is probably a form of rationing, but not really what we mean. Okay, rationing are stuff that we can give theoretically, we either because we have traditionally given them, and now we're choosing to withhold them, or we could give them and we choose not to. And I think nice falls into that second category. And usually there's more justification for the second category because often there's a reason why we didn't do it in the first place. This is also not where we've had a traditional treatment which has then now been shown to be somewhat unsuitable. That's not rationing, that's just changing policy. What this is there's a treatment we've traditionally given to lots of people, and we then limit who gets it due to various factors. Or we could give a certain treatment to people and we choose not to give it to them based on certain factors. So rationing is therefore the limiting of treatments where we have the capacity to give it. We can't say, for example, highly experimental treatments which are only just coming through are being rationed because they're not in a state where we could reliably give them, for example. Now, there are many reasons why the NHS is looking at rationing and is interested in rationing. And they vary particularly by group being rationed to and disease. So there are some being rationed, and there's probably the most politically charged attacks are on cost cutting. That the NHS needs to save money, that the NHS is in an unprecedented funding situation, and therefore while it might have traditionally given XYZ, or while it could have given XYZ, it needs to save money, and so it's going to cut this and that in order to reduce costs. In addition, related to that is point 3, which is the if there is a finite number of MRIs, a finite number of radiographers or chiropractors or clinical psychologists, then one has to ration who gets to see these individuals, these staff, these resources, by severity usually. So, for example, there is huge amounts of rationing in children and adult mental health care provision in London as well as elsewhere because of sheer shortages of trained clinical psychologists and psychiatrists. As well as that, some more nuanced and perhaps not as negative arguments. There's an increasing drive towards something called evidence-based medicine. Now, evidence-based medicine is very interesting. This argues that, to some degree, a lot of how doctors have traditionally treated people leads to something called overdiagnosis. Overdiagnosis is where, just to be sure, or because it can't hurt, inverted commas, patients were given treatments for certain things which actually doesn't make an impact. So, for example, antibiotics for a cold back in the day. Now, this school of thought says we need to be more evidence-based on the treatments we give, the drugs we prescribe, rather than just go, oh yeah, it can't hurt. Now, they're looking at this from mostly actually overdiagnosis can cause harm. If you give people drugs or treatments, there can be side effects. In addition, it has a psychological harm, etc., etc., etc. But there is a cost-cutting element to that as well. We can save so much money if we are smart about what actually is going to work. Now, the next point I would say is the most important one. And it's one that I tell my students always to lead with when they are doing rationing questions. And this is the idea that actually, in many ways, rationing is inherent to the NHS. I've already mentioned an example of inherent rationing with NICE and how they will limit drugs because there's a finite amount of money. I've mentioned in the past the GPs and their roles as gatekeepers, where they're not just here to see and refer, they're here to work out if you're important enough to refer and refer you up for those limited resources, or to watch and wait or otherwise, because you're not as serious and therefore you can be gatekept at a different level. In addition, there is elements of rationing where individuals are perhaps in a train accident. There's a finite number of ambulance staff and doctors available, and so you have something called triage, where you prioritise who gets access to these healthcare professionals, which may lead to people dying. And the idea is that this has the greatest impact to save patient lives. The final argument for rationing, particularly for certain types of rationing, and most controversially for particular types of people, is lifestyle rationing. And this is the one we're going to be focusing primarily on today. The rest of it we have mentioned elsewhere, as I've explained, or hopefully you can see in the previous sessions that we have run where they sit. So what is lifestyle rationing? Well, lifestyle rationing is, we've got a direct quote there, is the deliberate rationing, either by delay or indefinite rejection. So either by saying, you come back in 6 months, or come back when you have done X, or by saying, until you are X, you're not getting anything, for individuals whose lifestyle is deemed to have some medical impact. So, for example, if someone is obese, you say, rather than give you this surgery, you have to lose X amount of weight. If someone is a habitual alcoholic, rather than having the surgery, you have to quit drinking. The three sort of major criteria used, and in order of how problematic they are to ethicists everywhere, are listed there. On one level, there is an argument that if you choose this lifestyle, you need to keep the consequence or accept the consequence, and it is not up to the NHS to just subsidise and allow without any limit your lifestyle to continue. The idea that you made a choice to have that lifestyle and you've got to live with this choice to some degree, either by going to the back of the waiting list or either by not being put on the waiting list in the first place. The second argument is that these individuals, this is slightly more ethical, so I'd say emphasise slightly, is the idea that these individuals, habitual drinkers, for example, habitual smokers, the obese, their lifestyle will cost the NHS more than the average patient. These individuals are probably where a disproportionate amount of spending in the NHS is going. And therefore, it is both good for the patient and good for the NHS if this person changes their lifestyle. And so what's happening in this argument is that you limit the access to this particular procedure, whatever it happens to be, as an incentive structure to encourage people to change that lifestyle. So what we're trying to do is use access to healthcare as a public health tool. And you can see the argument. There are counterpoints, as we shall soon see. Finally, and I would say the most justifiable of our arguments, is that of cost effectiveness or effectiveness. That certain treatments are less likely to be effective with certain lifestyles. So one that occasionally comes up in an interview is an alcoholic who needs a new liver. And this argument is a finite number of livers, it's a dangerous procedure, it's a costly procedure, and there's a much higher chance that an alcoholic who is still alcoholic rather than recovered is far more likely to damage that liver and need a new one. And therefore the argument goes that you should ration and deny, on the basis of being an alcoholic, the liver until they change. There is some CCGs who ask that people who are certain levels of weight will not be allowed certain surgeries, such as hip replacements or knee replacements, which have a higher chance of failing than people with a certain degree of weight. Today, mostly, the people who are lifestyle rationed, when you look across the CCGs, are smokers and obese. This is to some degree either because these groups present the greatest financial cost to some arguments, or to others that these are the most socially acceptable people to ration, and therefore who you can get away with rationing. It depends on your political point of view, and that is for you to decide, not me. Particularly as we have seen, however, the rise in financial challenges in the NHS, and the shift under the Nancy reforms of CCGs, where you allow a lot of atomised and individual groups, subdivisions within the NHS to make their own financial decisions. We're seeing certain CCGs push this rationing or that rationing. Most rationing, apart from the ones I mentioned which are inherent, are on CCG levels. One that I haven't mentioned that's inherent, that isn't CCG level, is prescription charges, where obviously that's designed to sort of create a friction that is cheap enough that anyone, if they really need the drug, can afford it, but expensive enough that people who don't need it won't bother to go and get it in the first place, also as acting as a form of rationing. So, what are the arguments for and against lifestyle rationing in context? Well, in many ways it depends on what is rationed. Since the Foundation Trust, or the CCG, largely are just decide what is rationed, they have a very eclectic list. But in general, it tends to be elective or non-urgent or routine surgeries. Now, not just because these are elective, non-urgent or routine, doesn't mean they are not important. This includes many quality of life surgeries, such as hip and knee replacements, who, while you can get by, your significant limits on mobility has a significant impact on your quality of life and health elsewhere. So you should not see, just because they're not life-threatening surgeries, which is very rare to ration, and generally it's part of the inherent rationing, these are still ones that have a profound impact on the day-to-day life of individuals. Now, the problem we are going to have with this patchwork, ad hoc system where different individuals all have different experiences depending on the CCGs they're in, is that there's not really a consistent set of rules about how you can stop being rationed. The most common approaches are that you have to hit a certain weight, or a certain amount of cigarettes per day, or you have to attend a certain meeting or set of meetings. You have to wait a certain amount of months, or in some cases, you're just full on denied unless you can come back with it all fixed. Now, a bigger problem is it is one thing to tell an alcoholic stop being an alcoholic and then leave them to it. And it's a very different thing to say stop being alcoholic, and here is the support in place to help you in that one. Same thing for smoking, same thing for obesity. There's highly varying levels of support. And as we shall soon see, a lot of the arguments against lifestyle rationing is actually, because often this is a cost-saving maneuver, they tend not to come with support, because support costs money. And so what ends up happening is you end up rationing people on the basis of lifestyle, but not arming them with the ability to fix it, which then arguably leads to a contradiction and can be seen as fairly unfair. So, what are the major arguments that you could put forward at an interview in favour of lifestyle rationing? The first is cost, and I would say this is the biggest argument that one makes or one hears in interviews and the wider policy sphere. Essentially, this comes down to the fact that there's a limited amount of money, and there is therefore huge waiting lists, as there's a bottleneck that appears where you don't have enough money to have an extra MRI or extra staff in certain areas, and therefore as people increasingly are identified as needing a particular surgery or intervention, they have to join the back of the queue. And the argument goes that, well, many conditions are particularly aggravated or caused by obesity, smoking, drinking, or other lifestyle factors. And therefore, these individuals are costing significant amount of money to the NHS. If it is not that every person in the UK are equally costing the NHS, that these people, the argument goes that these people who have these particularly poor health behaviours are costing the NHS disproportionately more, and in order therefore that people who do not have these lifestyles do not suffer as a result, that there needs to be a limiting and in some degree a public health pressure to address these long-term lifestyle issues in order to deal with the costing issue. So the argument here can be moral. Why are we spending money? I say moral, I don't mean this is moral, but the idea is based on a moral argument. Why are we spending money on these people who are costing the NHS disproportionate? It can also be, if we go back to the previous slide, it can also be a sort of continuing cost argument, which is actually the part of the reason we have this crisis is these chronic diseases that are related to poor lifestyle factors, and therefore we need to use lifestyle rationing as a way to reduce the costs. So it's not just about punishing people who have spent their budget, in inverted commas. It's about, well, how else are we going to get people to improve their lifestyle and therefore save money? Chronic disease costs far more than acute disease. Lifestyle factors are particularly related to chronic disease. And chronic diseases cost money because often they lead to and require expensive surgeries. But worst of all, they are ongoing for the rest of the patient's life and often lead to comorbidities that only further cost money in due course. Now, there's also an effectiveness argument, which is very similar, which is the idea that actually, as I've mentioned, these conditions these lifestyle factors can make certain interventions less effective. The obvious one is obviously the liver transplant, stuff around mobility, knee or hip replacements, which are far more likely to fail and therefore far less likely to be a good use of limited NHS resources, NHS staff, or so on. So there goes the argument. However, there is worth bearing in mind here at this stage that many of this, so let's use the example of denying hip and knee replacements for the obese. Many of these treatments, in many ways, can only further be diminished because people with certain lifestyle factors then often have particular comorbidities alongside them. That only makes it even less likely to be worth it. That not only does this particular condition, to some degree, mean that the intervention is less likely to be successful, but the comorbidities, so that's other diseases that often come along with particular lifestyle factors, such as diabetes or high blood pressure or strokes in the obese, for example, only further make it less likely to be successful, which makes a calculation even further against. A counter-argument, obviously, to this, as we shall soon see, will be, well, hang on, if you take mobility away from the obese, how do you expect them to be able to deal with that lifestyle factor? There's also, and I would say this is the most flawed argument, but you do you, the most, the sort of more moral, I suppose, and again, I'm not saying that this is moral, but I'm saying this is on a moral basis rather than a scientific basis, per se, argument, which is, why should the NHS reward individuals who have not taken the sacrifice to look after yourself? It's nice not to. It's not nice to have to go running. It's not nice to have to sort of limit what you choose to do. But these people who have done all the right things, etc., 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 are now at the back of a waiting list with loads of people in front of them who are in that waiting list because of decisions they made. And the argument is it fair that people who have looked after themselves may well be at the back of a waiting list for certain conditions, may even die as a result, despite the fact that they did everything right because of the irresponsibility of someone else? That is how that argument goes. We can certainly agree or disagree with that one. And there's finally a public health argument. We need incentive systems. We need a way to incentivize people to shift their lifestyle, to change how they behave in their health behaviors. Because chronic disease is the greatest rising threat to the NHS, as we have seen. And as we've seen, the only way to deal really with chronic disease effectively is to prevent chronic disease in the first place, and therefore that requires changing lifestyles. Lifestyle rationing may not be the only way, they argue, but it is a helpful tool in the armoury in order to encourage patients to take responsibility for their own health. And in particular, advocates say, well, we're not denying forever. We are saying you have to hit certain points, and all they need to do is do that. And also, we're not denying life-saving treatment. This is encouraging, therefore, a way of people to improve but isn't causing harm. Now, we can, as I mentioned, debate that argument, but certainly no one's going to die over it in theory. So these are the four major arguments. You would never make all four in an interview, but you might want to sort of think about which ones most work for you, and if therefore you're ever asked about rationing, you can sort of look to defend it or counter it based on that. So if those are the arguments for, what's the arguments against? And I would say the strongest one, for me, against lifestyle rationing, I think there's very strong arguments for rationing in general. To some degree, it's inevitable in a system where it's funded by the government, or any health system, to be honest. But the strongest argument against it is that if you think about all these arguments I've mentioned here, apart from the fairness one, which has its own set of problems, there are other ways to go about this, particularly the prevention and cost argument. There are other ways to reduce like poor health behaviours, as we have seen. There are other ways to save money. That actually, why do we need to resort to quite harmful and alienating elements such as lifestyle rationing when we can try and work through other ways instead? There are also a significant number of other little arguments. Again, you are not expected to know all of these and not expected to argue all of these. I'm going to give you the sort of buffet of all the different arguments that one can make, and then you pick or choose 2 or 3, absolutely maximum. The first one is that this serves as what's known as the thin end of the wedge. You know, like a doorstop is like a wedge where you have a thick bit and a thin bit. The thin end of the wedge is a quote, or it's not a quote, it's a saying, which basically says that you often, if you want to get a massive change, you don't change all at once. You do a little bit in the most acceptable parts, and once people have got used to it, then you get a bit more and a bit more and a bit more and a bit more. Death by 1,000 cuts is almost argument. This is the argument that actually this is the thin end of the wedge of wider rationing, and in some people I even argue it's the end of the NHS to some degree. That if you allow rationing here, how long is it until you allow or even require rationing there or there or there or so on? The next argument is actually this is quite a negative underlying intent. That actually there's some fat phobia here, there's some elitism here, there is some elitism against the working classes who disproportionately smoke and drink in amounts and alcohols which the NHS say are worse than others, particularly in amounts and regularities. And And the argument here is actually what a lot of what the rationing is under is dressed up as medical science, but actually it's just fat phobia. It's just sort of discrimination against people whose lifestyles aren't as middle class as the doctors. The next argument is that, well, how do you have a fair criteria of why this weight gets it and why this weight doesn't? Why this many people who smoke and this many people who smoke don't? And this drinking a couple of glasses of wine is fine, but a couple more cans of Stella is not. How do you base that criteria? And related to this is the fact that actually a lot of the arguments, such as, well, this is less effective for the obese, is often based on anecdotal evidence, evidence which is not not statistical or quantitative, and therefore could be deeply flawed rather than any really big data evaluation. And a lot of the justifications, when you see the actual logical science behind it, rely on common sense and anecdote rather than detailed research about are the logic of this doesn't work or this makes people's life change or etc actually true. In addition, there's an argument that, as I've mentioned, a lot of the stuff you ration actually makes the poor health behaviours continue. You get rid of, for example, denying knee replacements to the obese only probably worsens the poor health behaviours. Saying that you can't have a liver and therefore you're going to die or have a terrible life can argue only make alcoholism worse in certain cases. Now, for me, the next one is actually probably the most important. If you do all of this, but you do not give support to improve the lifestyle, that is becoming what we might describe as punitive or punishing. And because a lot of the time this is being used to save money, there's really, at best, token support, like vague directions to an Alcoholics Anonymous meeting, for example. And this lack of support means that actually this becomes a punishing thing. That in theory, yes, but in reality, a lot of this is habit, a lot of this is education, a lot of this is addiction. And if you go up to someone who is an addict of some form and say, fix yourself and walk off, that is punishment. That is not necessarily about looking after the patient and putting the patient first. In addition, arguably, this puts quite a negative relationship and frames the relationship between the patient and the NHS, the patient and the doctors, in a really bad place. It will incentivize, for example, lying about your smoking and drinking, because if you increasingly realize that you're not going to get certain treatments, then you'll just be dishonest, which only makes your treatment worse because the doctors won't be aware. In addition, if you are a smoker, a drinker, or obese, it puts a profound strain on the relationship with your doctor and probably the trust of the doctor, which may have impacts down the line in terms of whether you go to see the doctor about something else, whether you trust the doctor or how you interact with the health system. And this can all have far worse and far more expensive implications down the line. In addition, this can therefore encourage patients to not want to access the NHS as much because they feel like they're being judged. In addition, if they got lifestyle rationed for one thing, they might not access the NHS for another thing where they wouldn't get lifestyle rationed, but because they got lifestyle rationed last time round, and it is probably a humiliating experience, they just didn't bother to go this way around because there's this fatalism that's crept in, which is, I'll always get rationed anyway, so there's no point. And so what you might see is these people actually are far less likely to access the health system, and when they do, they're going to be far more suspicious because, in their mind, probably rightly, they're in terms of their perception, they have been discriminated against. In addition, the groups with these lifestyles are disproportionately the most deprived areas of the country, the most deprived communities in the country. And so therefore, as we've seen in the health inequality session, this is a huge issue that needs to be dealt with. To then ration healthcare, to alienate the relationship with doctors and health system, to reduce the ability for them to be able to deal with this, and all the factors mentioned, only makes health inequality worse. And finally, there's an argument that actually this can have quite a toxic effect on the culture and the philosophy of the NHS. It is one thing to be an institution that treats everyone. As soon as you become an institution where it normalises, we treat everyone except for those guys because they live their life badly, as according to us, the argument follows that actually this can lead to creeping in an elitism and a culture of discrimination, which then gets transferred to other areas. Humans are messy. Doctors are humans, nurses are humans, and so on. It's very easy to transfer one set of norms to another set of norms in due course. And so what ends up happening, or what we can fear happens, is that by legitimizing fat phobia, by legitimizing arguably elitism against working class elements of working class health behaviours, you will then legitimize further behaviours and make that seem acceptable. So if we therefore add that up, we've got our fors, which do have a place, and our againsts. In the interview, generally the questions are posed as, what do you think? What should be done? And therefore it's going to be based largely on weighing up debates. You will need to think about what here works for you as your for, and you're always going to have at least one for, even if it's like, in theory, yes, or one could make the argument and then you no. We call that a straw man, where you sort of like put something up and then knock it down. And your no answers. It is better to fully explain a couple. I normally tell my guys 3. Because in an MMI 5 minutes, you're not going to have time to do much more than that. It's better to fully explain that and than do all of these briefly. Because remember that interviews are assessing, and we will cover some more details in a future session, are assessing your depth of understanding, not breadth of understanding. So therefore, you look actually quite weak if you mention all of this. Now, obviously, you look better than someone who doesn't mention any of this, but like in terms of hierarchy, someone who mentions very little and sort of gives a tummy gut emotional reaction is worst. If someone mentions loads of things randomly but doesn't explain any of them, they're middle. And then if someone is able to fully explain the implications and pass out and demonstrate understanding of the nature of the health system, medicine, and the role of doctor, while explaining 2 or 3 of these, they're going to do very well. So, does the lifestyle rationing have the place in the NHS? Essentially, rationing, as I mentioned, is inherent in the NHS. And if the question is just about rationing rather than lifestyle rationing, you might want to make that point. But lifestyle rationing, you can say that in some rationing of some types of surgeries, and for me it's, for example, the alcoholic who needs a liver transplant is a good example of this. There's nothing intrinsically wrong so long as you are smart about it and you give support. But the underlying problem is not the logic, it's how that has knock-on effects and actually how it's motivated by other considerations rather than healthcare. So, for example, rationing on the basis that this doesn't work for people with certain lifestyles is fine. But if you're doing it for other reasons, moral reasons, I remember I'm talking in a descriptive term rather than an evaluative term, or cost-saving reasons, that can get very contradictory. In addition, if you are doing this and not giving supports, that's a problem. If you're doing this on very flimsy basis of evidence, that's the problem, which is a significant problem. And what we end up with, therefore, is because a lot of lifestyle rationing relies on anecdote, relies on perceptions of what is a bad lifestyle, relies on people trying to find places to find money in the most socially acceptable way. What ends up happening is we have a real variation of who gets what, depending on what postcode you live in, and therefore what CCG you have, as well as arguably a discriminatory undertone to how decisions are being made and who is being isolated and who is not. So overall, in any interview question about rationing more broadly, you must remember that it is inherent, and there are good reasons for there are good ethical reasons for gatekeeping in the NHS, and there is good reasons for stuff like prescription charges. But with lifestyle rationing, we might want to take a bit more of a nuanced point. And a lot of my students, when asked a more general question about rationing, so not a question about lifestyle rationing, but just rationing in general, will often start with the positive sides to say, well, inherent in NHS, and talk about that, and then get into a bit of a debate about lifestyle rationing and say, but this form of rationing actually I have a problem with. So, while we need to have rationing, and there's a sense for this, this, and this, there is an issue with this. And while you can make this argument, no. You could, however, be a complete advocate for lifestyle rationing, fine. You could be complete against. So long as you can be interesting and show that you understand the problems, they're not going to judge you too much unless you say something absolutely out of this box. Which way you go. So it's about having an argument that you can argue, and an argument you can understand, and therefore talk around and maybe even answer follow-up questions on. Okay, thank you very much for listening. I will see you in the week after next. Until then, enjoy.